All right, hello, and thank you for joining us. The Southeast Mental Health Technology Transfer Center is pleased to present today's webinar event, ACT in Unprecedented Times, How ACT Teams Pivoted to Adapt to COVID-19 and the Ensuing Racial Unrest. My name is Emily Moore, and joining me in moderating today's event is Dr. Benjamin Druss, Director of the Southeast Mental Health Technology Transfer Center. Before beginning, I would like to take a moment to describe the work of our center, followed by an introduction of today's speaker by Dr. Druss. The Southeast Mental Health Technology Transfer Center is located in Atlanta, Georgia at Emory University's Rollins School of Public Health. We are proud to serve the 8 states in HHS Region 4. Our expertise in public health programs, systems, research, and evaluation provides a unique lens through which we can address mental health priorities. The goal of the Southeast MHTTC is to accelerate the adoption of evidence-based mental health programs by providing training and technical assistance to Region 4. We use a public health approach to build leadership capacity and to provide mental health trainings and resources to providers, agencies, and communities across the Southeast. We encourage you to visit the Southeast MHTTC website to learn more about our center and our upcoming events. I'll now turn it over to Dr. Benjamin Druss to introduce today's speaker.
Hi, everyone. Welcome. So it's really a privilege today to be able to introduce a close colleague, Dr. Helle Thorning, who is a clinical professor of psychiatric social work in psychiatry at Columbia University. Dr. Thorning serves on the leadership team of the Center for Practice Innovations in the Division of Behavioral Health Services and Policy Research at the Center for Practice Innovations at the New York State Psychiatric Institute at Columbia University. There, she is a research scientist and the director of the ACT Institute. Dr. Thorning completed her bachelor's degree in psychology at the University of Copenhagen, her MS at Columbia University School of Social Work, and her PhD at the Silver School of Social Work at New York University. An experienced clinician in hospital and community mental health, Dr. Thorning is also a licensed clinical social worker, training clinicians and working with people facing mental health challenges and their families in the US and abroad, and has a practice in New York City. So with that, I'll turn over the slides to Dr. Thorning, and we're really looking forward to hearing from you today. Thanks.
Thank you very much, Ben. Thanks for that very nice introduction and kind words. I'm just going to take a few minutes to share my screen. So you can see my slides. Are you able to see my slides? So I will take that for it.
Yeah, we
yes.
We see it.
Okay, great. And let me just take one more moment to set up so that I'm all set. Okay. Okay, so welcome everybody for this morning's presentation, and I'm very pleased to be talking to you about what's going on with ACT right now and how we see how we have all pivoted the work with COVID-19 and also the ensuing racial unrest. So I'm going to try to cover a number of different areas today and really talk about where we are now, and also really thinking through where we are going with ACT as we move forward, and the lessons that we have learned. And I hope that you really join me in this today's conversation, and it's really a time for us to all kind of bring together all the knowledge that we have gained in these past many months. That's been very intense and very difficult on so many different levels. So these are the learning objectives that I'm hoping that you will walk away with, some of these kind of considerations and thinking about it. but I really encourage you to participate as much as you can in the chat box with your comments and your thoughts and your observations and what has worked and what hasn't worked. Again, we really need to think about out of the box, thinking about how we can continue to serve ACT participants in with our ACT team, so that they ACT really serve such an important function in our mental health system, in that it serves people who are in between sort of a hospitalization and also in the community. So in that space, we are there, ACT teams are there to really provide support and treatment and guidance for people to work towards on their journey, or their work towards their recovery, their personal recovery. And so we need to be very thoughtful and thinking about what we can do as our world has changed, as we have a new normal, and how do we do that? How to do intensive outpatient treatment when we have so many challenges? So just a quick word. I'm, as Ben said, I'm here in New York. I oversee the ACT Institute. We provide the training and support for our ACT teams throughout the state. We have 108 teams right now, we do a number of different things from the ACT Institute, but primarily around training and implementation support. And also we have been serving as a platform for ACT providers to have a place to talk about what's going on right at the moment, and how we can best serve and work under the circumstances. So as we get started, please introduce yourself in the chat box so we can see who is here. Your name, your ACT team, your agency, and where you are. In this time of most of us working from home or in some hybrid format, it's very important for us to form communities. So this may also be another opportunity to get to know your colleagues who are working in ACT in the southern states. So please join me in introducing yourself and to me, and also to your colleagues. See, a few people are doing that, and I'm going to keep going. So please, as we move into my talk here and our discussion, you can continue to add to the chat box. So welcome, everybody. So I'm really going to talk about things in kind of like 4 chapters. I was going to call it the Act 1, 2, the four acts of ACT here during this time, but I decided to stay with chapter. So chapter 1, chapter 2, chapter 3, and chapter 4. So this year we really had a regular start up, right? We did ACT as usual. But then in March, when COVID-19 happened, and this pandemic, and we really became clear that this is a pandemic, we really had to pivot very quickly on so many different levels. So I'm going to talk about that. And then already in April, there was another pivot. There was another event that happened that really stirred the country and stirred all of us up, thinking about what happened with George Floyd and the murder of George Floyd, and the intense scrutiny and observation of police brutality, white supremacy, and racism is something that we are now all kind of thinking about, and that also impact our work on ACT teams. We want to talk about that. And then chapter 4 is really thinking about what are the lessons learned. We have been working from home. We have been working in new ways. We have learned some things that worked and some things that were more challenging. But what can we take, and what can we take and use going forward to keep adapting and making the ACT model relevant, and be able to rise to whatever challenges that we are encountering and we are met with. So chapter 1. So chapter 1, everybody's working as we are on the with ACT. We have a team, we have a shared caseload, we have very clearly defined roles, we know what we are doing, direct treatment, care coordination, we meet with people, and the high frequency, and there's a low patient to staff ratio, and we outreach to the community. This is what we do. This is a model. ACT has been around for a long time, and when it's practiced as intended, we have the best outcomes. So these are all things that we know. We have a team. We all working towards helping the person from a person-centered treatment approach gain health and health, and we work on substance use and mental health. Really, these 3 areas, and we all work together in a collaborative effort. We also have a shared mission and vision. We know our team, we understand how we work together, and we have a framework and structure for team dialogue and collaboration. With our structured daily meetings, shared responsibility for all ACT participants in the team, and we have our organizational tools that keeps us on task and also knowledgeable about each of the ACT participants and their current situation. So then chapter 2, COVID happened, and we had to pivot due to the health risk, not just for ACT participants, for ACT providers, but for communities. But I think what was so interesting to see is how ACT, with our infrastructure that I just talked about, the way that ACT has been laid out and really thought about in terms of working as a team, working as a unit with the ACT participants that we serve. These daily meetings and the way we communicate, we were really, most teams that we observed in New York, and what I've heard from the rest of the country, that people were able to take that daily meeting and just simply have a different form of communication method. And that was and people used all kinds of platforms, like the Zoom platform that we are on now, or Microsoft Teams. But in fact, some of the ACT teams had already begun to take some of the tools that we had built up around ACT in terms of the whiteboards or the way of tracking everybody on an ACT team, their progress or their particular challenges, and scheduling appointments on a daily, for the daily or weekly basis. Some teams had already begun to move those online and use various technology and using the social media that all of us perhaps use now in terms of WhatsApp or text messaging to stay in contact with one another during the day. So that actually had begun already in my experience, and what I've noted to also happened before March, before COVID, but that there was really a very easy pivot to then continue the work of ACT just in a different way, but still within the same structure and within the same framework. And then begun to think about how do we then provide a service like ACT, which is an outpatient. It's we out in the community. That's really the hallmark of ACT. So how to shift that over to doing that using telehealth or telephonic methods. Now that was a challenge, and I'm curious to hear whether that was a challenge for you too. Not everybody on an ACT team, the ACT participants have telephones or smartphones, and so that took a time, a little while for people to kind of get established how they could communicate with the ACT participants. The other thing that happened also early on was this idea of triaging. ACT teams triage all the time, but now they also had to consider which of the ACT participants on their teams really had to be seen in person, that it was vital that they were seen in person. Also, if there was particulars around medication and if people were on long-acting injections versus what could be pivoted to using telehealth. So the triaging, I think that ACT teams do, they just do it. This is the way they operate every day. I think in particular as those decisions are made during morning or the daily meetings, then taking into consideration who could safely be seen using a telephonic service. And then underneath that, and so part of that is also assessing risk and harm to others or harm to self. So is how do you manage if people had a concerned about violence or also suicide, and how it that became a big focus also on how to do that when you are not able to kind of immediately go out into the community to meet with a person, but you had to kind of find other ways of doing that. And then again, expanding our understanding of safety, meaning now when we talk about safety in the community, we are not only talking about the ACT participants, their families, or the communities, but also talking about in a much more direct way, provide a sense of safety because COVID is such you really have to think about if you're being exposed and then bringing that back home in a different way than we had to think about it before. Who is that who are we living with? Who could we potentially expose by bringing COVID back home? So I think that, and also for many of our app providers, we also learned in a way more about providers' vulnerabilities and vulnerabilities towards COVID that had to be taken into consideration. So these were some of the things that where ACT were able to pivot and continue the work, and which is in a very, very impressive way, but had to now add other dimensions to the work. And I'm curious to hear if you have other thoughts about how else you and your team pivoted. What other ways was important for you to think about how to change the work? And what new practices did you and your team adopt to kind of meet some of these challenges? I'm going to give you a few minutes and so maybe jump in the chat box and add some of your thoughts about this. Okay. So I'm looking at who is here now, and I can see you from many different parts. I see people also from different parts, not just the Sun States, but I see people from Oregon, Pennsylvania, Maryland. This is really about Kansas City. So what else? Florida. Wow, we really have wonderful representation. So I see that, so from Olga is saying here that morning meetings via WebEx, telehealth appointments with the doctor, the nurse practitioner, train the team on creative ways to engage clients by phone. Yes, exactly. So how did you do that? How did you engage people on the phone? And Suzanne is saying, I don't belong to an ACT team. We used to have a PACT team many years ago. Oh, okay, you're trying to get an ACT team again. Wonderful. And you've also been here that you've also been totally on using telehealth since COVID. Yeah, so these are really things of how to engage people really with using telehealth. It's really a new skill that we all had to learn. And one of the things the most I heard from our peer specialists, that they began to do, cooking together on Zoom. They began to do really, each of the specialists were able to find ways of thinking about how to engage people with what they currently were interested in learning, but also taking the opportunities to use the time that people had to spend at home to do some of the things like begin to think about work, thinking about for the vocational specialists, how could you begin to look for work, thinking about what kind of work you wanted. So I think each specialty role on ACT really had to think about how to use the tools that you have at hand, that you use, the practices that you use, that you might have done sitting side by side, but then using a platform like WebEx or Zoom to really communicate with the ACT participants. And then morning meetings, as somebody is saying here too, on Zoom. And so that is, I think, was pretty clear that we could pivot. And what was interesting is that many of the things that we thought before COVID that we couldn't really do, we actually have been able to do, and people have been able to work from home, and finding ways of communicating that will be important for us to think about as we move forward. So I'm curious if you could also share a positive experience with an ACT participant or their family social support that happened with in this new environment that we are working in, and maybe also share a challenging experience with an ACT participant. Give you a few minutes to jump in the chat box. This is also what we are learning now. If we had been in a room together, I could have seen sort of where you were at, and kind of see who was ready to talk, and we could have more and easier conversation. But now we're also learning to communicate in different ways, and using many meetings now. I see you use this hybrid of chatting, asking questions, and also ways of giving people information and resources right then and there, using the chat box function. I'm going to share just one of the peer specialists. The two things that I heard that particularly struck me as really a very positive way of engaging. One was with a young person who was leaving, had actually been incarcerated, was being moved to one of our ACT teams. And he was able to, people were quite concerned about meeting him and then engaging with him in a very critical time, from moving from one place, from a forensic setting out into the community. But what they found, which I thought was so interesting, is that there was no sort of travel time, or they could in fact be more in touch with him than they had been in other situations. So that as he came into his new living situation, that the ACT team was involved with him on a regular or daily basis, could really problem solve and troubleshoot with him, and that was really important for him to settle into the community and getting through that critical time. Another peer specialist did many sessions of wellness sessions, particularly exercise sessions. And I think many of us have also learned that we don't necessarily have to go to the gym, but that we have gotten involved with our online, classes, exercise classes, and to bring that also to ACT participants was something that really another way of kind of engaging around issues of, like, let's say, wellness exercises, and then as another way of helping people sort of get used to that kind of format, and maybe, could be something that people can continue on their own, since so many of these types of exercises became available for free to all of us during this time. So those are some of the experiences. I'm going to read what Suzanne is saying here. I had many positive experiences over the months using telehealth. I have many folks who are homebound and who have no supports without my calls. I've been able to intervene in crisis situations when needed. On the flip side, it's been hard to engage some of my clients who are tired of all the calls and wondering when it's all going to go back to normal. Yeah, well, I think, Suzanne, I think that's a very beautiful way of describing it. That, yeah, and maybe some of us are beginning to feel a little bit of Zoom fatigue, or being on these Zoom calls all day long. But and maybe that's the same experience our participants have or our clients have. But I think the idea is, kind of figuring out ways to do it, and keeping sort of a practice going around it that can be useful for everybody going forward. But I think we have learned that it is possible. So so as we do this work in a new way, my challenge to you, and to kind of question about, the importance of, the teamwork is even more important during times of crisis, or when things happen that are so unexpected and so unprecedented. So my question is, like, when we are working on a team, it's not just knowing the roles that people have on a team, but also who the people are behind the team roles, and how well do we communicate with each other about who we are and the issues each of us on a personal level are also facing that might be getting in the way, or being particular obstacles or challenges when you're working in a new way. And why is that so important? I think all of us can sort of say that it is important, and that we probably will agree on that. The COVID-19 pandemic, the way I think most people are kind of thinking about that, it is really a shared trauma for both ACT providers and participant alike. And I've listed some things here, but you may also think about, well, how has this impacted you as a provider? And also, how is that similar or to also the ACT participants and their families or their social supports? So when we think about a shared trauma, we see that often, when there's a community trauma, such as a natural disaster or a man-made event, and we certainly learned that in New York after 9/11. But I think also with a pandemic, as we are facing now, that there's fear of becoming ill, or being exposed and making somebody else ill. There's certainly loss and grief. We have had so many tragic deaths. We have also a loss of what, as Suzanne was saying when she's talking or recounting what some of her clients are saying, when are we going to get back to normal? Yeah, we have loss of what the way things were. There are things so you could be together, you could hug somebody, you could give people a handshake, you could see your family. I mean, that's a loss of the way things were. Some people who who are living by themselves are also very isolated, again, as you mentioned before. And some people are living in very close quarters, and many of our ACT participants are also living in congregate housing. So people have either isolated or too many people, and many of us are working from home while also providing caregiving either for an elderly person or having children who are also going to school from home. And that became a huge challenge. So, and I think Donald is saying, yeah, there's also fear of the uncertain future. That's really right. When is this going to end? How is our what is life going to look like? When? And I think, you know, as we are, you know, coming up on Thanksgiving and the holidays, that has also, you know, caused a lot of anxiety and stress from anybody I know in my personal circles, but also in my circles of colleagues and of ACT participants, that everybody's sort of thinking about how are we going to do things. And holidays often for ACT participants who might be disenfranchised from their families or have burned some bridges or trying to reconnect or have lost children to, for lost custody of their children, that holidays often brings up even more vulnerability for people who've been separated from their families. So in this situation with the pandemic, that is also a huge kind of area of that's causing great sadness and grief and maybe other things. So if other things on this list, I'm sure I'm not capturing all of the different issues that can come up when you are in a situation that's so unexpected, and that it's also not ending right anytime soon. Please keep adding to that. So anyway, so then we move into chapter 3. And so soon after COVID-19 really became clear that this was this was something real, for real, that we really had to pay attention to and change the way we worked. There was also the death of George Floyd and the ensuing social unrest due to the questioning of white supremacy, police brutality, and racism. And a new pivot, the ACT teams too also, and ACT providers, to understand, well, how is this impacting the impact of racism and police violence, not only on our Black and Brown ACT participants, but also our Black and Brown colleagues. And that, I think, really was although this is not a new issue, we all have learned that this is not a new issue. This has been going on for a very, very long time in this country, that this became really highlighted. And how we think about this as an ACT team is also quite important, because we are working with many of our ACT participants are also people of color. And we also work, many of our teams are also quite diverse, people coming from different race, different backgrounds. And how do we think about that together when these very, very things, tension in communities also impacts the way and impacts our behavioral health and mental health. Okay, I just see Maria just introduced herself. I'm Maria from Pennsylvania. Nice to have you here. And Donald also saying it has hindered the progression of the successful recovery treatment from going to the next step. So that's also kind of thinking back about how these things that are happening in our environment and the challenges in our society also have kind of an impact on our ACT participant. So I'm going to do a very quick discussion of sort of why is this is so important to think about social determinants. We need to think about them, and I think we're beginning to think about them more, thoughtfully and carefully with the work that we do with ACT participants. But I think it was really quite highlighted with COVID, and how COVID has really impacted people very differently. If you are a person of color, Black or brown person, the likelihood of people dying from COVID is greater than if people from white communities got COVID. And so there's really a disparity in what the sort of the outcome or sort of the consequences of COVID. And that kind of highlights the experience that we have in our country in terms of how someone who is at risk for poor mental health or risk from mental illness. So I think this, there's a lot of talk about social determinants and sort of looking at the impact. And I really like Compton and Sheem's diagram here, because they really bring in sort of and I think you can follow my arrow here, but all of the things that are the psychosocial issues that people experience in terms of, I'm going to start up here from underemployment to food insecurity, poor access to quality of mental health care or health care, education inequality, poverty, income inequality, poor neighborhoods, social exclusion and social isolation, housing instability, adverse early life experiences, which we know from the ACEs study that really lays that out, and talk a little bit more about that in general. So you have this sort of snapshot is what this inner descriptions of these boxes with these different areas of social determinants. But then when you take that into the historical context of long-standing, and that's a bottom bar down here, historical and socioeconomic and cultural context in the US, where cultural and societal norms are pertaining to social position, prejudice and exclusion and racism really impacts. And from a historical point of view, we know that intergenerational trauma has an impact on people's current lives. And then the top bar here is what's happening right now. So if you think about how COVID, and if you took an X-ray, so a colleague of mine had that analogy. So if you take an X-ray of the United States and you see where the hotspots are of where people are, where the areas of higher contagion of COVID, you will see that they are in areas for people with people from Black and brown communities, but also who have impacted by these other social determinants. And I see that Jean of Fensky from New York City just announced they'll be dispatching mental health workers and not police for calls when individuals experience a mental health crisis. Excellent point, Jean. I saw that too, and it was very exciting, because I think that's actually the next, so you're giving me a good lead into the next portion. I'm going to get back to that in just a second. So for the ACE study here, where you see the adverse childhood event, really this pyramid, and I'm sure many of you are familiar with this, but again, the pyramid with generational or historical trauma, social conditions, adverse childhood experiences that disrupt neurodevelopment, and then has all these impacts, adoption of health risk behavior, substance use or cigarette use that are leading to disease and then to early death. We know this impacts our people in the with behavioral health challenges, and of course many of the ACT participants. So structural racism, just to kind of say that the way our society of mental health services are really constructed is based on race, and so when we talk about structural racism, it really this cartoon kind of illustrates sort of the differences in terms of we may have the same distance to the goal, our personal goals, but the way and the obstacles for each person, white people versus people of color, Black and brown communities, that there are really the very great disparities that we have to pay attention to and think about. And if you have an opportunity, you might want to see what else you see in this picture that kind of illustrates the points that I'm making. Somebody mentioned that the only sort of hindrances the white man has is that he's wearing a suit, and that makes it maybe more difficult, but really very few obstacles to get to his goal, whereas there are very built-in obstacles for the woman of color here. So when we talk about structural racism, it refers to the totality of ways in which society fosters racial discrimination through a way of reinforcing systems of housing, education, employment, earnings, benefits, etc. And these patterns and practice in turn reinforce discriminatory beliefs, values, and distributions of resources. And this is, impacts the ACT participants. And I think for our brown and Black colleagues, we also have to think about the impact that this has on their lives, and how we as white people have to, really recognize that and think about that very carefully. And the barriers then is this long history of structural racism, also BIPOC, Black, Indigenous, people of color. By mental health system creates mistrust. Treatment decisions are often made without the voice of service participants and their family or natural supports or communities. And culture and race is not considered in both the ideology, what happened to people, or why someone developed mental health challenges or in the treatments that we offer. So these are great challenges to us as providers of ACT services. So are there, just for a question for you, how else do you think structural racism impacts you and your work with ACT participants? I'm going to pause for a minute here to give you a moment to think about. This is a big question. Jackie is saying difficult choice doing someone who looks different. Yeah, thanks, Jackie. Or perhaps if you were a person of color and you were treated by a mostly white treatment team, you may have had other experiences with white people that has been where you've been feeling where you might not have been seen, where you might have had been discriminated against. And then to think about, what that's then like to seek mental health services from that. So really very good to think about what these differences. And then Olga is saying sometimes it takes longer time to build rapport and trust. Yeah. And to think about how you engage with that. Okay. And Lex is saying clients not feeling heard or respected based on their cultural values that inform how they would like their care to look like. when their culture values do not align with how the dominant culture wishes to treat the mental health condition. Oh, thank you, Lex, for that. Suzanne is saying, occasionally I work with clients who express racist belief. Yeah, so that's another thing. So that also poses questions and challenges for mental health providers. Thank you for those. Please think about it. And if you think about something, you'll keep an eye out for what you're saying, because this is something we don't often talk about. And also something that's not so easy to think about on our team. So I'm now going to talk a little bit about chapter 4, which really is thinking about how do we go forward from here, and I call it act adapting or adjusting, perhaps, because maybe it's more of an adjustment and an adaptation. And maybe it's a challenge that we can think about together. So while there's a growing interest in understanding how social factors drive poor health outcomes, identification of structural racism as a root cause of health inequalities has been neglected. And I think that's all something that we really are witnessing right now. And then, so as we think about we move act forward, how do we focus on patterns embedded in policy and practices that reinforce discriminatory beliefs, values, and also then have these very negative impact on social behavior and economic outcomes? Big questions for all of us, and as we work in doing our clinical work. So my question is, how do we do this? How do we take some of these thoughts and things that we have learned through COVID and things that we have maybe avoided, not really brought into our services and understanding of services? How do we do that? I'm challenging you to think about it and put some thoughts into the chat box. And I'm going to keep looking. Okay. So I wanted to see if you can consider whether you and your team have practicing, first of all, from a trauma-informed care perspective, meaning are you looking at sort of what, instead of thinking about what's wrong with people, right? We talk about what happened to people. And when we talk about what happened, we also have to take into consideration racism, oppression, and discrimination, things that have impacted people that we serve. And also thinking about whether stress or racial stress and how that also impact the team. So Suzanne is saying we have been going through a lot of training in this area in the past few months. Yeah, I think you're not alone, Suzanne. This is something that we have been talking about. And so how do we bring it into also thinking about how this fits in? I'm going to bring it back now to the ACT team and how we can do this work together. Lex is also saying we do a lot of trainings on clients' autonomy, trauma-informed care, and multicultural perspective, the importance of understanding of clients' culture, ethics, racial, religious, etc. background in providing care and respecting their voice. Excellent. Donna is saying in some aspect it's brought to light the issues of cultural differences, having a common goal of surviving together in the pandemic environment. That's actually, yeah, so really that's the idea that I like that both of what you're saying, that it really brings in sort of this idea of something that we are sharing, coming at it from different perspectives, depending on what color your skin is, but also, and what resources you have available to you, but also there's something that is shared trauma, right? So it is a complicated kind of matrix to kind of sort out and really understand that my experience with COVID-19, where I can I have the luxury of being working from home. I have the luxury of having food delivered to me, the word luxury or privilege really. And then for people who must go into work and who are in a different kind of risk category, right? Because of that. And who is that? There's also a race, and we need to understand that from a racial perspective as well. So building a show. Oh, so now we have heads up, 10 more minutes. Thank you very much, Emily. I'm going to bring it together here. So teams, well, how do you do this? How do you think of bringing these conversations into your team and ensuring that you continue to work on how your team is doing? So obviously ACT teams do that all the time, consistent, frequent team meetings. You check also in with one another to really understand, and this is an important point, getting to know people also behind the role and what are the unique stresses and considerations everybody needs to do the work. And practice, really think about value each ACT provider and their contributions, and practice trust. I want to offer up a model of kind of thinking about bringing these conversations to your team, because the way that you operate is as a team. If you can talk about these things with your colleagues and really understand the different experiences you have, but also most importantly, the experience of your BIPOC colleagues, that will also, if you can have this conversation, we know a lot about parallel process in treatment situations between supervisor and supervisee, but also amongst team members, so that you have sort of a shared way of talking about these social and racial disparities that so impacts ACT participants and also ACT colleagues. So this is a model where that you can use, and you can think about it, where if you notice something, and I'm going to take you through this model, if you notice something, you set aside time to discuss, reflect, and then name it. And when you do that sort of in this circular feedback loop format, that will lead to some action. And you'll be able to think about, if you are delivering services in an anti-racist practice way. And when you are doing this kind of reflections, the questions you might want to ask is, how does the content and what we hear now affect the interaction between myself and the ACT participant, or myself in relationship to my ACT colleagues? What power dynamics do we notice? What assumptions may be taken for granted? Can we challenge them? And what larger societal and structured power dynamics are implicated and active in those current interactions? Now, so this requires having a brave, creating spaces, we call them brave spaces, where you can have these dialogues, and also a place where there is, and there are often these conversations that people probably have experienced with all this training that you've received, that these can also be very uncomfortable. So this is hard work. And for all of us, and particularly, I would say, for white people to be able to really understand the experience of BIPOC communities and how that impact our work and our assumptions, so that we are not forcing or coercing treatment, that we are even in subtle and in maybe with implicit or explicit bias. This we know from the ACT Institute, what we have done, and also with the ACT teams, is we have provided some platforms for people to talk about these issues together and sort of facilitate a conversation. And that has been tremendously helpful in creating these as we call, embrace spaces. And the feedback we then have had is that to have these dialogue about white supremacy, relationship with law enforcement, for example, coming up and just quickly saying, commenting on the issue about law enforcement, that I think behavioral health providers, we had sort of a go-to message on our answering machines that if people couldn't reach us, they should call 911. Now we know that has led to some very, very tragic outcomes. And so we really have to rethink that relationship. And as some places are beginning to talk about, as was mentioned before, that you have to, that maybe social workers, behavioral health people, or peers are better equipped to manage or intervene if there's someone who has a mental health crisis. So we have looked at these conversations and the feedback we have received, and what I also have experienced personally is that I don't feel so alone and isolated. And I'm so grateful to have a forum to exchange information with other providers, both in the same situations as myself, and also learning about the experience of my colleagues. And it's important, and also that people could share their personal and family challenges and racial stress. Okay, thank you, Jean, who has to leave, unfortunately. I will read that. I want to end up sort of the most important part here is to think about self-preservation in doing this work during this time. So who is taking care of you and your team? And there are no one methods I think we all have learned during this time, but important to really take care of you and your team. And I want to want to hear from you what kinds of ways that you have, what has been helpful for you, what's been helpful for your team. And the team I work on, it's been helpful that we have stayed in touch, that we have had some also times where we just kind of talk about what's going on with one another, but also we have had these carved out space where we also talk about the impact on racial unrest on ourselves and what we do. So we kind of carved out spaces for all of that. And then, so I don't know how your teams have done it, but I really hope that everybody thinks about this idea of taking care of yourself and your team, and really incorporate self-care practices for teams. And you can do that on Zoom too, in terms of playing games and enjoying one another when we have to do it sort of from home. I think this brings me to sort of this question. Suzanne is saying staff means we assume a team means teams weekly, talking with other colleagues to decompress. Yeah, taking personal time off. Yeah, excellent. Attending webinars and training. Yeah, that can be very, rejuvenating, right? You get new ideas and fresh look on things. So teamwork is important, and I think the sort of self-explanatory now after we have talked about all these things, but having time to process what's going on, to learning how each of your teammates are doing, to build a strong team, and that way we can shift some of the cultural norms and pivot towards collaborative practice where all participants share understanding of social determinants and stress or racial stress. So on that note, I think I've come to the end. Thank you, and be well and be safe.
All right, thank you so much, Dr. Thorning, for that amazing presentation. We've now reached the Q&A portion of today's webinar, and I think we have time for perhaps one question before we move on to the evaluation survey required by our funder. So if you have any question that you would like to submit to Dr. Thorning, please feel free to type it quickly into the webinar chat box, and we will get to, I think, one question before we move on to evaluation. And that's a question for us for the MHTTC. We have a evaluation survey that you will fill out after the end of this webinar, and then that evaluation survey will take you to a certificate of attendance for your records. All right, if we have no other questions, Dr. Thorning, would you like to give any closing remarks before I introduce the evaluation survey?
I see all the things that people are writing in the chat box. Thank you so much for joining me here today, and let's keep this conversation going as we move forward. So thank you and be well.
All right, thank you so much. Everyone, the Southeast MHTTC would like to thank you for your participation in today's event. We value your feedback and invite you to evaluate our event. Please complete a brief SAMHSA required survey by visiting the link presented on your screen. Completion of this survey will provide information to SAMHSA and assist us in planning future events. Afterwards, you will be automatically redirected to additional questions from the Southeast MHTTC regarding the impact of this event on your knowledge and skills. There you will have the opportunity to download a certificate of attendance for your records. Please allow about 5 to 10 seconds for your browser to redirect you. Again, our center appreciates your participation and feedback. We hope that you will join us for future events. Please visit our website to learn more. And thank you again to Dr. Thorning for such an amazing presentation. This concludes today's webinar. Thank you very much.